Hello, good morning. Happy to be here. So my name is Noha. I'm a pediatric postdoc research fellow at Indiana University, and I work with Dr. Hannon. And I'm very happy to present our project on GLP-1 receptor agonist choice and change patterns in pediatric type 2. So as we all know, pediatric type 2 is rising, and GLP-1s have been increasingly used to improve glycemic control and weight outcomes. And despite this growing use over the past few years, real-world pediatric data about, choice, switching, and discontinuation remains limited. So in our project, we aim to characterize these prescription patterns and identify reasons for switching and discontinuation in our population of pediatric type 2. So this was a retrospective chart review at our Peds Endo Clinic over the course of 6 years. We included patients aged 7 to 18 who were diagnosed with type 2, and we abstracted visit level data on both demographics and GLP-1 prescriptions. So we had a total of around 850 patients who came to the clinic 3,400 times. 60% were females, and the majority were insured. They had public insurance, followed by private insurance, and a negligible number were self-payers. So over the course of 6 years, we had 37% of visits ending with a GLP-1 prescription. So zooming in on the graph on the left, three main things to note. If you look at the small box on the bottom, which I don't think you can see back there, but I'll try to tell you some of the numbers. So looking just first at clinic visits, in 2019, we had around 260 visits, and that increased to 780 visits in 2024. Then looking at the height of the bar graphs, which illustrates the number of visits that ended with a GLP-1 prescription, and focusing on the axis on the left, which shows the numbers, it increased. So was this increase actually due to an increase in visits, or were more visits ending with a GLP-1 prescription? Well, I'll direct you to the line graph, which actually shows the percentage. In 2019, around 10% of visits ended with a GLP-1 prescription. That increased to around 21% in 2022. And then right at 2024, we have 63% of visits ending with the GLP-1 prescription. Looking at the pie chart on the right, overall, prescriptions over the past 6 years, 60% of the scripts were just continued scripts, followed by new scripts at 27% and switched scripts at 14%, which is to be expected now that GLP-1s have become more established at the practice. Then we go on to look at GLP-1 prescription composition, looking at what agent providers chose to prescribe. Early on in 2019, you can notice the blue that designates dulaglutide, and the red designates liraglutide. So they were really key players in 2019, but liraglutide, the red one, sort of took over in 2020 and 2021. And maybe side note, you can kind of guess why. Maybe we'll talk about it in the end. In 2022, we have this emergence of the green, which is semaglutide, and then which continued to obviously 2023 and 2024 with minimizing utilization of liraglutide, again, the one in red, in the last 2 years. So looking at the new prescriptions, so what was the agent that was prescribed to patients as the first GLP-1s? Mainly it was dulaglutide at 43%, followed by semaglutide at 29% and liraglutide similarly at 25%. So this was the agent that was chosen to be prescribed as, the first introduction to GLP-1s for that patient. Moving on to GLP-1 switches, you have this heat map. On the left, you have the from agent, and on top, you have the agent that the patient was switched to. Looking at the really dark blue lines, we can first focus our attention on the switch from semaglutide to dulaglutide, which was our most common switch. And that was mainly due to insurance. At around 90%, that was the driving reason for patients to be switched from semaglutide to dulaglutide. Then focusing on switches from dulaglutide and liraglutide to semaglutide over on the right, that was mainly due to the weight loss benefit that was found in semaglutide as a drug. And finally, the switches from liraglutide in general to all the different agents, looking at the third row, mainly liraglutide was switched to both dulaglutide, exenatide, and semaglutide, and that was mainly due to also insurance, but also adherence, given that liraglutide is a daily injection. But taking it overall, the main reasons for driving a switch were insurance at around 50%, followed by weight loss benefit and some unclear reasons at the chart. Other reasons that we might think, like availability issues, side effects, adherence, and treatment plans, were contributors, but they weren't the main ones. Switching over to GLP-1 discontinuation, it was discontinued at 58 visits. Here we see an emergence of two reasons, like patient preference and side effects, and they were key drivers to discontinuing GLP-1s, while previously I told you that they had a really minor role in switching, but insurance is also a key player here. So in conclusion, in our study, in our cohort, dulaglutide was the most prescribed and most frequent switch target among pediatric type 2 patients. Insurance coverage was the leading factor in medication choice at the beginning, and switches, often overriding clinical preference. And other factors like perceived efficacy, tolerability, and side effects played a role, but to a really lesser extent. Thank you.
Okay, thank you so much. And any questions? I can start with at least, so when you say the continuity of prescription, is that a prescription or it's the patient taking it? Like, how did you look at those prescriptions through just the drug list?
So looking at the individual visit level data, looking if the patient had been taking the medication and if it was renewed. So that designated a continued prescription.
Okay, that means that they were taking it and they were continuing. So that's a good data, yeah. And I'm assuming that the terzepatide is still not commonly used. It's because it's relatively newer agent than other agents, and it's taking a time for prescriber.
You can see it in the
percent.
that was mainly from patients who were on clinical trials and also followed up at clinics. So it's a really minor contribution.
Hi, Janine Sanchez, University of Miami. You mentioned that some people switch because of not a sufficient weight loss. What about diabetes control? Would anybody switch for that reason?
Yeah. So on the left, you can see treatment failure contributing to 3%. So so in the chart, it was designated as either wanting to switch for a weight loss benefit. Mainly, they were switched to semaglutide, but they were also switched to other agents very rarely, or they were designated as having failed treatment, and that's why they had switched them to another agent.
Grace Kim from Texas Children's. Any issues with getting the semaglutide covered?
Mm-hmm. So as you can see with the switches, semaglutide, the main reason for switching out of semaglutide was insurance, about 90%. And I think the data honestly underestimates that because sometimes providers wanted to prescribe semaglutide, but they knew that it wouldn't get approved. So, and that was sometimes written in the charts, but also what I know anecdotally. And so I think insurance is a really big role, and the data does show it, but I think it also underestimates it.
CMI Kasha, current children. How often would you see this patient as a follow-up in a year?
So again, I'm a postdoc. I don't see the patients, but from the charts, usually patients are started off at 3-month interval, 3 to 4 month intervals, sometimes progressing to 6 months, 8 months, or 12 months, depending on glucose control.
Hi, this is Praneet Brar. I'm calling from NYU Long Island.
Nice
This
if
was
you
really helpful.
extend this project to really look at the efficacy of these different agents over time and what happens in terms of both A1C as well as the weight loss would be an extension of this project.